right, it's 10 o'clock. We'll give folks a few more minutes to come in, and then we'll get started. There's a lot going on in the world today, or in the country, so just wait a few more minutes. Hopefully we have some folks join. Okay. I'll get going. And as people join in, they'll join the conversation, ask questions, those sorts of things. So I've been doing these for a few weeks now. My name is Dr. Dunbar. I'm a private practice doc in Portland, Oregon. I have a clinic. It's called CereVite Direct Health. That's also on Instagram, which you can find on Instagram. Good morning. How are you? It's good to see you. And we've been doing these sessions for a few weeks now. It's called Menopause and. We've been sort of walking through common symptoms of menopause as well as some less common ones. So we've done night sweats, we've done sleep, we've done bowel, like GI stuff, and then we talked about sensory perception. That was what we did last week. We had a guest come in and talk to us about that, which was amazing. That's sort of a lesser known symptom, but again, we're finding as we have these conversations, people are raising their hand and saying, oh my gosh, that's me. So hopefully you've been able to join. They're Thursdays at 10 o'clock Pacific time. And my goal again is just to open up the conversation around menopause. In healthcare, we don't get this in our typical training. As a family doc, I didn't get menopause treatment as in my normal course of education. Most OBGYNs haven't. So docs that do it have gone back, right? They've gone back and done additional training to have this as a skill set. For me, I'm going through perimenopause and I'm like, okay, this is craziness. So I've taken the time to sort of dig into it a little bit more as a function of just being better prepared for my own patients. That's my motivation, is to sort of be a resource and be helpful. So if I see that, folks are asking me questions and I can't answer those questions really well, and then that's my job to go back, right? And get versed on the topic and bring sort of the medical slant to it, help people understand where the research sits, what are our options, those sorts of things. So that's my goal with doing this. And again, I also have a private practice where I see people directly. It's called direct, or the model is called direct primary care, where patients, it's just the two of us. Insurance isn't between our relationship, right? We get longer appointments. My patients can text me or email me. I answer the phone when you call if I'm not directly with another patient. And we get to spend more time and we unwind all the things that people have been dealing with. What's your health vision? What sort of health do you want to create? What kind of future are you looking for? And we work together to get people healthy. I'm really about prevention. It's always better to prevent, but if people come to me and they're already living with disease, then how do we start to unwind some of that? How do we fix some of that root cause that's led to type 2 diabetes or high blood pressure, cholesterol? And then in this context, what do we do to make our bodies as metabolically healthy as possible to help us through this transition of perimenopause to menopause? So that's kind of the goal. Again, my private practice is CereVite Direct Health. You can find me on Instagram under that. You can also reach out to me directly through here. I'm pretty accessible. So today I was going to talk about hair growth or thinning or losing hair related to menopause. Reason is I got asked, right? So a friend of mine says, what is this minoxidil and what are the side effects and is it safe and those sorts of things. So that's usually how I get my topics, is someone asks me questions. So please ask questions. If there's something you're wondering about, like, gosh, is this related to menopause, or what do I do for this? Send me those questions, because that's what I try to address. So that was the topic for today's menopause and kind of hair growth or hair thinning. So before I kind of go into the kind of like the how do we treat it, I want to just back up a little bit and help people understand, how do we grow hair? Like, what's involved with growing hair? Because I think by setting that, then that'll help us understand the treatment and what are some options for treatment. So hair growth is, the hair, first of all, is like reproducing constantly, right? So it's a very cellularly active and metabolically active organism. So if you think about it, because of that rapid growth, our cellular health and our hormonal health is integral and necessary in order to support that kind of rapid turnover, right, to grow new hair. So the key hormones that come into play, estrogen actually physically helps with hair growth. Then there's progesterone. Progesterone's goal is it decreases the conversion of testosterone to another product called DHT. DHT itself actually will suppress hair growth. So again, progesterone's job is to reduce the amount of DHT running around, right? So that you can grow hair. Then you've got, again, testosterone. So if you have a lot of testosterone, or testosterone converts to DHT. So if you have a lot of testosterone, you're going to have more DHT, which reduces your hair growth. So the idea is you want to have a low level of DHT in order to support hair growth. Then you've got your thyroid hormones. So your thyroid hormones come into play with kind of how healthy the hair shaft itself is, right? So how thick your hair is. So your thyroid hormone comes into play. Then cortisol. If your cortisol is really high, that's going to decrease your hair growth. So again, high cortisol decreases your hair growth. Then there's insulin. If insulin is really high, that's also going to convert more or make more DHT, which as we said, right? So DHT actually reduces your hair growth. So the higher your DHT, you're going to lose hair. So more insulin, more DHT means you're losing hair or you're thinning hair. So those are the things that control hair growth. So as you can imagine, if we think, let's just take them one at a time. Insulin. I talk a lot about being metabolically healthy, right? Are we able to convert the food that we eat into energy? Our cells are constantly trying to make energy, and in the process of doing that, we create waste. When we aren't able to keep that waste product at a low level, the waste they're called free radicals, right? If we have an overabundance of free radicals, that term is called oxidative stress. That oxidative stress leads to us being metabolically unhealthy. What it leads to is higher insulin levels. So if you think about it, most traditional docs are checking a fasting glucose when you go to your regular doc. If you're going at least once a year, they'll take a blood test and they look at your fasting glucose. Well, what's happening 5-10 years before that is insulin is slowly rising because it's doing its damnedest trying to lower your glucose in your circulation. So the higher your insulin is staying up, eventually it's not able to keep that glucose low. Then you start to see a higher glucose on the lab tests that we do in traditional healthcare. But 5 or 10 years prior to that, your insulin has been creeping up. So again, higher insulin means your DHT is higher, which means it's going to start to decrease your hair growth. So again, those that are living with prediabetes, your insulin is high because we know that because your fasting sugar is already high. And as a result of your fasting sugar staying up high long enough, now all of a sudden you've got an elevated or a high hemoglobin A1C, which is how we diagnose prediabetes. So if you're living with prediabetes, if you now haven't changed lifestyle, haven't got metabolically healthy, not because you don't want to, it's because maybe your doc isn't telling you how to, or you don't have the right support, then now, gosh, you're type 2 diabetic. That means your insulin's high, right? So then that increases your hair growth and makes for an unhealthy head of hair, right? So that's how insulin works. Then we look at cortisol. So we said, again, if cortisol is high, that's going to increase hair loss. Cortisol is a stress hormone. So most of us, we all have stress. We can't avoid that. But we sort of live with this low level of stress, right? If we're not getting enough sleep or really restful sleep, our cortisol level stays up high. If you're waking at 3 o'clock in the morning, that means you likely have a high cortisol level. So again, if you've got a high cortisol level, that's going to increase your hair growth. Your hair loss, right? So again, managing our stress, making sure our cortisol level is staying high, that sort of general kind of fight or flight that's like constantly running in us, although it's at a low level, that's cortisol. It's a sympathetic hormone. So making sure we're bringing our cortisol level down will improve hair growth. Then we've got our thyroid hormone. And usually, again, traditional healthcare, we will usually test something just called a thyroid stimulating hormone. And if that's normal, then the lab usually will not reflex to the actual thyroid hormones, which are T4 and T3. We know that you actually convert T4 to T3 in your gut. So you can have potentially a normal TSH, but have a low T3, which is the active hormone. So again, in my practice, I test all three when I test people because I want to know what's going on underneath, and do we need to correct that because someone has, let's say, an unhealthy gut, right? So your gut's not healthy, so then you're not doing that natural conversion. So if we don't have a healthy amount or a normal or optimal amount of thyroid hormone, then that leads to kind of an unhealthy hair shaft. So your hair is really thin, doesn't have the thick hair shaft. So thyroid hormone is super critical. And then we know estrogen and progesterone. Those are the ones that, again, specifically to menopause, as those decline, then the health of the hair changes. Progesterone, remember, is the one that actually suppresses, it decreases the conversion to DHT. So when that progesterone starts to decrease, now you've got more DHT around, which leads to unhealthy hair and potentially hair loss. Testosterone also starts to decrease in menopause, right? As we get wiser in our years, we have a lower level of testosterone, which hopefully will lower the DHT, which helps us, but then that progesterone is going away too, right? So those two are kind of working in opposition. But then you lose your estrogen as the estrogen. So then you've got more things that are worsening your hair growth than you have potentially helping you. So those are all the hormones that are involved in sort of growing hair. And this is like a constant process, right? So if we think about it, as those hormones adjust, that sort of sets the stage for us potentially losing our hair. The other thing I would encourage people, though, when you see your doc is, again, you really need somebody that's going to be watching the whole picture and not just saying, oh, this is menopause. Let's make sure we are ruling out other things and doing the right sort of tests. So reasons for hair loss, you've got kind of, I'll say, like age-related or androgenic alopecia. Alopecia is hair loss. That is probably 85-90% of the reason men lose their hair. And it's up to about 50% in women. Anywhere from 20 to 50% is because of that. Then there's the bucket of other. And what that other is, menopause is certainly in that bucket. Autoimmune diseases can cause thinning hair. Stress, like we talked about, that cortisol staying up there. Again, imbalance in your thyroid hormone can certainly do that. Some medications can increase our risk of hair loss. And then kind of diet, right? Or vitamin deficiency can increase our risk of hair loss. So you need to have a doc that is really watching all of that and making sure that they're checking all of those things before we back ourselves into, oh, it's just menopause. Because unfortunately, in fact, I saw something just recently where, someone saw their doc and they're like, oh, it's just menopause, you'll go through it and then you'll be fine. You don't need hormone therapy. Or that's just, it's normal, it's menopause. No, do not take that as an answer. Don't accept that as an answer. Like, make sure they've ruled out other things. And even if it is menopause, well, you deserve treatment, right? You deserve to know what your options are, not just to say, oh, that's just menopause. Because hopefully what we're getting through all of this is menopause is not just about treating symptoms. Estrogen is wildly important for our overall long-term health, our brain health, our bone, and our heart. So just sort of poo-pooing us and saying that's just menopause and not talking about treatment, whether that's hormonal or otherwise, is grossly negligent in my mind, and you need to find another doc. So make sure they're checking other things And if it is menopause, well, then what are we going to do about it? And do we need to consider hormone therapy, non-hormone therapy? Do you know the risks and benefit of each one of those options? And what are your options? So those are the conversations you need to be able to have with your doc. Someone who's willing and open to have those conversations is paramount. So we've got, sorry, I went off on a tangent. I apologize. Any questions? I've said a lot. So any questions thus far? I'll pause for 2 seconds, but also just feel free, chat, dump it in the question box if there's anything going on. If I haven't addressed it or if something comes up, just put it in there and then I'll make sure to catch it and come back if I need to. But I'll pause for 2 seconds to make sure nobody out there has any questions. Okay. All right, so we've got the androgenic alopecia, which again, 20 to 50% for women. And then there's the bucket of other. So autoimmune disease, making sure your doc is making, you don't have any symptoms that would be concerning for an autoimmune disease. Thyroid can kind of be in that bucket, right? Then vitamin deficiency. So the main ones are going to be iron, vitamin D, and B12 deficiency. I'll spend a couple minutes on B12. B12 is a vitamin that we get if we choose to eat animal products. So animals eat, most of them are vegetarian, right? They eat grains and rice and all of this stuff. And in their gut, when they digest that food, they make vitamin B12. So we get vitamin B12 if we eat animal products. If we choose to not eat animal products, then it is a supplement you will need to take because then you're not getting it by virtue of eating an animal that has made it in their gut. So vitamin B12 deficiency can be a real thing if somebody's not eating a ton of animal products. I choose to not eat animal products. I eat cheese every now and again, but that's about all of the, or egg if it's like cooked into something. So I take a B12 supplement because I know I'm likely not getting B12 by any other source, so I take a B12 supplement. So vitamin D is another one. Again, traditional healthcare says we shouldn't be checking people's vitamin D level. It shouldn't be used as a screening. So there's a lot of, not regulations, but you get flagged and healthcare systems don't want to pay for it and insurance doesn't want to pay for it and all this other jazz, right? But we know that vitamin D is converted in our skin. First, we have to be eating the building blocks, and then we need to convert it in our skin into vitamin D. So I check vitamin D in my patients, and for me, I get wholesale pricing directly with LabCorp, so I don't have to go through insurance. And I think it's like $12 or $17 or something like that to check a vitamin D. So it's pretty inexpensive if you go wholesale in cash. If you go through insurance, they get to decide what you can order and what we can't order. But I check vitamin D because I want to know, is your vitamin D normal? Again, vitamin D is wildly important for bone as well. So we want to make sure that we're checking and supplementing vitamin D to an optimal level. So vitamin D is something you want to check as well. And then iron, making sure your iron is normal. And you can have iron deficiency without having anemia. So again, usually, in some cases, we'll check what's called a CBC or a complete blood count in people once a year. Maybe more if somebody's, we're watching something, maybe less frequently. So the CBC will show us your hemoglobin and your hematocrit. That is to determine if you are anemic. You can not be anemic, but be iron deficient because it takes time to present as anemia depending on how iron deficient you are. So, good morning. How are you? Welcome. So again, if you just get a CBC and that's normal and you don't necessarily check for iron deficiency, you're going to miss that. So making sure that we're doing that additional step and that you're working with a physician that's doing all of that work to be sure that we're not missing an iron deficiency. Because again, iron deficiency anemia, vitamin D deficiency, and a B12 deficiency are the three usual vitamins, 2 vitamins and then the iron, that if you are deficient will increase your rate of hair loss. So for those that just joined, we're talking about menopause and hair loss or thinning, right? So the things you can see are your hair starts to thin. So just like the thickness of it, you may notice if you have a part, the part starts to maybe look a little wider, or just frank, like hair coming out in the shower kind of thing. We'll also notice a change in our texture of our hair that can happen. And we talked a little bit about how we make hair, all the hormones that are involved in making hair, which is a rapidly cellular process, right? It really requires a lot of turnover of our cells to grow new hair. So it's a pretty dynamic thing. So there's a group of hormones involved. And then we were just getting into kind of the other causes of hair loss. Autoimmune, vitamin deficiencies is where we were. And then stress. So stress is cortisol. So cortisol, again, if it's too high, it's going to increase our rate of hair loss. So are you managing your stress? What's your stress relief? Are you getting enough sleep, right? So again, sleep deficiency, and really less than 7 hours of sleep a night is considered sleep deprivation. Ideally 7 and above, and we want to be restful, because if we're not, then likely our cortisol is going to stay up too high. So either we're not getting enough quantity of sleep, or the quality of sleep is not great, or waking up really early. That's an indication that your cortisol is spiking. That's what brings you out of sleep, right? If your cortisol starts to spike at 3 o'clock in the morning, then that wakes you up. So if that's happening, that's an indication that your cortisol is too high, and then you need to be working with your doc. And what do I need to do? Let's dig into your lifestyle. Let's address that, because getting you sleeping through the night is going to be huge, right? Reducing that cortisol level. Then of course there's menopause, right? As we start to lose estrogen and progesterone, we'll start to thin our hair. And then there's medications. In rare cases, some antidepressants, statins, which are used for high cholesterol, and then also some blood pressure medications can cause hair loss. So again, it's about, is your doc watching the store? Are they checking all of these things and really have a good command of all the different levers that we need to pull and maximize in order to create health? So making sure somebody's checking all those things. Pregnancy, obviously, right, is going to cause some hair loss. Usually pregnancy, that's like you'll get thinning hair, lose hair, but then once the little peanut is here, sadly, then you don't get any sleep, and then cortisol. But that's more of a finite amount of time, assuming there's no other underlying reason for it, right? And we just listed all of those. Any questions around just those things as far as the hormones involved, and then the other reasons, and then we'll kind of get into some treatment options. Okay. All right. So let's talk treatment. Maybe we'll start with medication, not because I necessarily think that that's the best, but we'll talk about that, and then I'm also gonna talk about more supplements and some foundational things that I think are important. And honestly, I would make sure this is dialed in first, right? The foundational things. I'm very much a lifestyle kind of root cause doc. So for me, it's unwinding and correcting the things that are modifiable, that are creating disease in people or creating symptoms. Fix that, right? And then if we still need medication, we can certainly go to that. And there's also nothing wrong with saying, okay, we can start a med while we work on kind of root cause, while we fix the foundational things. So when it comes to medication, one medication is called minoxidil. You can use it as a pill, or it comes like in a shampoo form. The topical is much safer because it's not a systemic thing, so it's much safer. It's shown to be fairly effective. I think when we think about treatment, the earlier we start, generally speaking, the earlier we start, the better, right? If you've lost, 20, 30, 40% of your hair volume, there is a point. The challenge is we don't quite understand where that point is, to say, gosh, the hair shaft is just so degraded that it's just not going to grow, or it's not going to come back. We don't know where that sort of break point is. It's not quite well defined, but generally speaking, we see people do better the earlier we start. So if you're starting to see hair loss or hair thinning, or the texture's changing, the sooner you start to talk about that and start addressing it, the better results we'll get. So topical minoxidil is one. Again, relatively safe. Works fairly well the sooner you start it. Then there's an oral pill, or a pill that you can take, minoxidil. It's actually, it can change your blood pressure though, so it affects your blood pressure. And it has some anti-inflammatory effects. The reason it affects your blood pressure, it's what we call like a vasodilator. So if you think of your blood vessels as like a tube, and we can give you medication that can actually kind of dilate or open the tube a little bit, or it can constrict the tube. So minoxidil opens the tube or dilates the blood vessels. That's why it helps with blood pressure. It has some anti-inflammatory properties, and then also some anti-androgen properties. So again, works with those androgenic hormones. So the thing we need to be careful of if we're going to use minoxidil, because it changes your blood vessels, make sure we're not causing any problems if somebody's already on a blood pressure pill, or if somebody has really low blood pressure, just inherently, maybe oral, or the pill form of minoxidil is not the best, because we may lower their blood pressure even more. So being mindful of that, then we say maybe topical is the right way to go if that's where we want to start. And topical minoxidil is a great first option. Again, very low risk, well tolerated. So that's really like everything we do in medicine is like risk versus benefit, right? The benefit is we say, okay, starting this medication or this treatment, we're trying to, solve for a symptom. But then what's the risk with that? So when you think about topical minoxidil, there's benefit and there's really very, very low risk. Oral, now we're kind of ratcheting up the risk because of some medication interactions. So topical is fairly well tolerated. One of the side effects, though, you'll see with minoxidil, it doesn't discriminate where you grow hair. So you may see some hair growth on your head, and you'll see hair growth anywhere else that you grow hair on your body. So that's a potential side effect, right? For men, maybe it doesn't matter. For women, it might be just depends. So that's one of the side effects, is that you will see hair growth everywhere. One other option is something called Propecia. That decreases the amount of DHT. Again, DHT is the thing that sort of causes hair loss. So when DHT is high, you'll see an increased amount of hair loss. So this particular medication, its job is it works directly at DHT to reduce the amount of DHT, so then hopefully you can grow hair. So that's another option. There's red light therapy, or laser therapy it's called. There's another medication called spironolactone. That also works at DHT to try to lower that amount of DHT. It's used for like cyclic acne, cystic acne, it's a blood pressure medication too. So again, potentially some interactions there. So that's also an option. There's ketoconazole, which is actually an antifungal shampoo, but that has been shown to help some hair growth. And then there's something called PRP, which is called platelet-rich plasma. As a sports medicine doc, I use PHP more in the orthopedic space, so like rotator cuff, tendon pain, knee arthritis, into the joint. So I use it in an orthopedic capacity. But PRP, platelet-rich plasma, has been around for a while in the sort of this space. So both for hair as well as like face derm type stuff. So that's an option. It's not covered by insurance, so you'll have to go to someone, and that's a cash pay thing. So those are kind of like medication options when it comes to treating hair loss. Now when we think about like root cause, so if you think about it, right, high insulin creates more DHT, high cortisol leads to hair loss, stress, cortisol, hair loss. So again, being metabolically healthy and addressing any sort of dip in our hormones, estrogen and progesterone, is like foundational things. So nutrition comes in big with that. So making sure we're getting enough. One thing that has been shown to work really well for hormones is like beans, right? Beans and legumes, as far as working as a phytoestrogen. So things that sort of act like estrogen, but they aren't really estrogen. So beans have been shown to do that, beans and legumes. So making sure you have a diet that's rich in beans eating, chickpeas for breakfast, or, making your own, I'm drawing a blank, like hummus or something like that, right? So beans, having a diet rich in beans. The other option is you take a supplement, a phytoestrogen supplement. doTERRA, it's a company. They're really plant-based. They've done research in large medical institutions, Johns Hopkins included. So I recommend their products. I think their products are fantastic. They have a phytoestrogen line, or a product called phytoestrogen, that can supplement your nutritional intake, right? To create, again, something that binds to those receptors and acts like estrogen, that has no increased risk for cancer and breast cancer and those sorts of things. So taking a phytoestrogen supplement on top of sort of really catering or creating a nutritional pattern that is centered around whole food that looks like food. Eat your beans, very low to no processed food, very low to no added sugars and refined sugars. Processed food, refined sugars are like gasoline to our cells as far as metabolic dysfunction. So removing those things entirely or having them in extremely low quantity is the best first step to trying to create metabolic health, right? That ability for our cells to create energy and decrease the amount of waste that our body makes in that energy production. Because again, all that waste product just starts to back up. And eating what are called antioxidant foods. So antioxidants are what sort of suppress free radicals. So you want to suppress those, but if we're making too much, because we're either eating more than we can deal with, and then the waste product that's generated by trying to convert all of that creates an overburden, which is called oxidative stress. So again, nutrition is huge. Exercise works fantastic for cortisol. There is a short-term spike after exercise. That is normal. That's okay. It's when it never comes back down. It just sort of stays up there. That's the problem. So exercise is, over the long haul, wildly beneficial for, again, metabolic health and being able to deal with all that food and nutrition, and making sure it's high quality nutrition that we're bringing in. So phytoestrogen is a supplement, and then doing everything we can on the nutrition side. And then rosemary oil is another thing, and it's topical, and you want to actually get it into the roots, not just like on the hair shaft, but like work it into the roots of your hair. It has a pretty pungent odor to it. So some people are using it like in a leave-in conditioner, or putting it on and then leaving it on for a few hours. So whether, I remember back in the day when I had longer hair, when my mom was doing my hair, leave-in conditioner, I put the shower cap on and I sit in the shower cap for a little while, and then you wash it out. So you want to leave it on for a few hours, whether you're spending the night in it, or if you got a Saturday and you're not running around, you can work it into your scalp and leave it on the hair for a few hours and then wash it out later. So rosemary oil is another option from a supplement standpoint. But again, addressing that foundational health, making sure our cortisol is good, our thyroid hormone is good, which comes into gut health, right? Eating your fiber is huge for gut health. I think we've talked about gut health before, and Akkermansia is a particular bacterial strain, which again, you can take a supplement, but then making sure you're getting enough fiber is what creates short chain fatty acids, which helps your gut health. So foundational stuff, your nutrition, are you sleeping well? In the sleep one, we talked about making sure we rule out sleep apnea, right? People aren't, if we're concerned about sleep apnea, making sure we're getting tested and treated so that we get good sleep, so our cortisol comes down. So treating the foundational things, using supplements, and then all the way to prescription medication when needed for hair loss. So that's all I had for today. So anything come up for people, questions, or I was telling in the beginning that this topic was because somebody asked me a question, and I said, let's do that as a topic. So if there's questions you have, that's kind of what I want to address. I mean, otherwise I kind of have my list, but I'm free to jump around if there's a particular thing that's burning for people that they want me to address. I talked a lot. I don't like to talk. I love it if people ask me things, so then I can engage, right? Interact with other people. So, well, maybe what I'll do here, there is, I mentioned it last week. So in an effort to continue to sort of create community around this, I will continue to do these, but I've started kind of a private social community because I want us to be able to continue these conversations between the Thursdays. And then I have folks coming in to dive a little bit deeper. So one topic is genitourinary symptoms in menopause, which deals with, like our risk for chronic UTIs, our risk for like vaginal atrophy and painful intercourse and those sorts of things. Sex drive starts to change. So that's a little bit more of a sensitive topic. So I'd like to do that in that private community. So I created it so that we can continue the conversation and be able to have more in-depth stuff in there. So there's experts I'll bring in to have those, deeper conversations. We have supper club next Monday, where we can cook together, or you just come and eat and we just fellowship and have community. There's a book club. We're reading Good Energy in there, which has a lot to do with this metabolic health. So it's just a way for us to have our own space. So before I officially launch, which will probably be in the next couple weeks, if folks are interested to get in now and just sort of see and help me make it a good space, I'm happy to let people in for free, just to kind of get in there and start creating an atmosphere that's helpful and people are willing to, if you're willing to join and give me some feedback, I would love it. So if you want to do that, just send me a direct message. I'll get you in now. Otherwise, I'll officially launch, probably early February. And there will be a nominal monthly charge to join. But I really would like to make it a really good place for people. I'll be there giving talks and doing those things as well. So it's another way to if you're not ready or you're not in Portland and you can't see me as a patient, it's a way to still have access to docs that are in this menopause space. So if you want access to that, let me know. So someone was saying, yeah, was that cortisone? Is that what they were doing? So you've got a question I was using, or a statement I was using the injections, but they didn't work. I'm wondering if they were using, are those cortisone injections or is it PRP injections? I'll see if she responds, but those are usually the two. Most dermatologists will do kind of cortisone injections to try to stimulate the hair growth. So cortisone is an anti-inflammatory, right? So we're hoping that we can stimulate the hair to grow. But again, the big thing is, have we addressed kind of the foundational stuff, right? So addressing any of the foundational things, like, is insulin high? Is your cortisol high? Are we eating things that are going to support our estrogen and progesterone production? Are we sleeping well? These things may seem a little bit harder because we're not going to see it like an instantaneous response, but addressing those things will make any treatment that we do more successful and then give us longer term benefit. So addressing the foundational things. So I don't know if that's something that your primary doc taught, because I'm imagining you went to a specialist for the injection. If your primary doc, whomever sent you to the specialist, yeah, right. So if they're not addressing that foundational stuff, and that's a challenge with healthcare. Yeah, that's the challenge. Primary docs, sometimes don't have that breadth of knowledge, not because they're doing anything wrong. I don't want to poo-poo my colleagues. One, I think I'm very different. There are a lot of lifestyle medicine docs out there. I don't know too many here in Portland. It's a growing sort of discipline. So really being preventative and lifestyle focused, addressing root cause, is something that's foundational. Yeah, the dermatologist probably wouldn't have that as their knowledge base either. They're a specialist, right? So their world is even smaller than a primary care doc. So primary care, someone like me, we're kind of, we know a little bit about a lot of things, And then again, my having, added education in lifestyle medicine, added interest in root cause and prevention, I spent a lot of time doing CME and reading so that my breadth of knowledge is even wider, I feel, than maybe some other primary care docs. And then when you become a specialist, you really narrow your focus. So you probably aren't spending a lot of time on these other things. So it's really the primary care physicians are the ones that should have, that breadth of knowledge to say, are we treating root cause? Are you metabolically healthy? Because that's what takes care of 80 to 90% of what we take, what we give medications for in healthcare. If we could get people metabolically healthy. And a lot of times, again, if we treat that with some supplements, you may not even need the specialist, right? So long term, it saves dollars, and people get better care for it. So I'm sorry that that's been your experience. I'm sorry that that's your experience. Yeah. But hopefully this was helpful, because now you have the knowledge, whether that's to go back to your primary doc, or if these are things you're ready to implement on your own, then yeah, right? So hopefully this is helpful to understand that even if those injections didn't help, that if there's room to really modify that underlying, then you can do that and hopefully see some bigger benefit. Okay. And then obviously happy to see you if that would be helpful too. Oh, wonderful. That's great. That's great. So you're doing phytoestrogens, which is awesome. Have you done rosemary oil? If you haven't, you could try that. And then I would say, again, where is just, examples of, how metabolically healthy are you? What do your labs look like? And then just if you think about your lifestyle, right? Do you sleep well? Are you exercising regularly? Okay. That's an option. But again, addressing the other stuff, right? Sleeping well, exercising regularly with lifting. And then what's your nutrition like? Those are like the very beginnings of it. And if those are all dialed in really well, then you could potentially try the rosemary as well. Yeah. Okay. Anything else I can answer? This is the other reason to do kind of the community, right? It's a quicker interaction. So we can jump on a Zoom and we can all be in a Zoom together and we can talk and see each other and make community, and save our fingers from doing all the typing all the time. So, okay. Well, thank you for joining me. Again, my name is Dr. Dunbar. I have a private practice here in Portland, so Ceravite Direct Health. Happy to help anybody. Take a look at my website. It's ceravitewellness.com. And then obviously, if you're interested in joining the online community, happy to get you in. That's a place to get to me between Thursdays with questions. And again, we've got Supper Club Monday night at 5 o'clock Pacific time for those that are in the community. And we've got some expert sessions coming up pretty soon. First one is going to be in, I think, end of February or March. Alrighty. Thank you so much. Have a great day. Take care. Bye-bye.